Alrighty, so welcome back. Today we're going to be tackling shockable versus non-shockable rhythms. So this is a really fundamental aspect of cardiac arrest management, especially if you are heading towards an advanced level, to understand the differences. And I've kind of picked up that this is a pretty good breakdown of knowing which rhythms are what and kind of the why, right? I'd always want to recommend that you assess or think about the why of whatever we're doing. So what are the shockable rhythms? Shockable rhythms are VF and VT, right? Pulseless VT. Your non-shockable rhythms are your asystole and your PEA, right? So let's break these things down. First of all, the thing we need to break down is what exactly is defibrillation, right? Why do we defibrillate? What does defibrillation do? So defibrillation doesn't restart the heart. Defibrillation stops the heart, right? It's kind of like you take your hand and you smack the rhythm flat. That's exactly what we're doing. That's what defib does, right? It just flattens the rhythm, hopefully into an asystole, so that then the SA node, the sino-atrial node, can take over. Why would we want to defibrillate? So let's go to our shockable rhythms. So our shockable rhythms, let's start with VF, so ventricular fibrillation. The word tells you what's happening. So the ventricles are fibrillating. That just means that all the cells are trying to depolarize and cause the heart to contract. So all of the cardiac cells can actually depolarize themselves. And what this does is that it just causes chaos, right? So we see a rhythm like this. So this is ventricular fibrillation. It can be really broad, it can be really fine, so kind of the amplitude can change. Generally speaking, we get a patient who goes into VF and then it's very broad and then it narrows, and then becomes very fine VF, right? So we can kind of talk about how to manage it later if you stay tuned. In this rhythm, all of the cells in the heart are trying to contract. It's kind of like a group of people all trying to talk at the same time, and it's just not very productive and nothing is actually generating any forward blood flow movement, right? So do we want to stop that? Yes, we want to stop that craziness because nothing good is actually coming from it, right? We want to defibrillate that because it's just craziness in the heart. How do we pick up, or how do we recognize VF? So it's just a squibbly line going from left to right, and it looks like a toddler could have drawn it, right? There's no pattern, there's no rhythm, nothing is regular about it. It's just random up and down movements. That is your VF. So let's go to VT, right? So pulseless VT. So pulseless because we need to check for a pulse before we shock it. We don't want to just shock VT. That's not quite within the scope of our conversation today. I do have some videos that you could probably watch about that if you wanted to. We would probably do a synchronized cardio version on that patient if they're unstable. But back to this is that a pulseless VT. Why would we want to shock pulseless VT, right? So VT stands for ventricular tachycardia, which just means that the ventricles are firing too fast, right? And so we are now not generating any forward flow, right? So the heart isn't doing what it's supposed to do. Do we want to stop this? Yes. Why would we want to stop this? Well, because the ventricles are firing so fast that there isn't enough time for the ventricle to fill up and then for it to then get the blood out, right? So your preload and your afterload are all messed up because there isn't enough time for filling of that ventricle. How do we recognize VT, right? So VT, ventricular tachycardia, so any ECG rhythm, any rhythm that has a really broad QRS, and if it is regular, right? So rhythms can look quite varied. So you can have different kind of rhythms like these, and these would all be VT. There's a good chance that the atria or the SA node is kind of, lost within all this ventricular movement. And so all you're seeing is these ventricles, right? Often looks like a shark tooth. And that's just a very broad QRS. Do we want to stop this? We do. Defibrillate that, right? Because it's chaotic, it's not generating any forward flow, right? It's not generating enough cardiac output. So we defibrillate. So those are two shockable rhythms, right? Then our non-shockable rhythms are asystole and PEA. So let's start off with asystole. What does asystole look like? It looks like this, right? It's actually not perfectly flat. It is kind of a sine wave. So if you zoom in and you create very high gain on your ECG, you should see a slight line that kind of moves gradually up and gradually down, and that is your asystole. Would we want to shock asystole? No, because if we shock asystole, we're just going to make it more of a flat line, which means we're just causing damage to the heart, right? We don't want to shock unnecessarily. So shocking asystole would be pointless because it's already flat, and the point of defibrillation is to cause flat lines. So hopefully the SA node takes over, but that's just not going to make any difference in this point, right? So asystole, we're not shocking because it wouldn't generate any benefit. Then PEA, right? So PEA stands for pulseless electrical activity. So how do we tell the difference between a normal sinus rhythm and PEA? Well, the answer is a pulse, right? If there is a pulse, it's normal sinus rhythm. And if there's no pulse, it's a PEA, right? So a normal sinus rhythm could also have all sorts of different varied views. So it could look like any of these, but these are all PEA if there is no pulse. Do we want to shock a PEA, right? Do we want to stop that? No, we don't, because what's happening in a PEA is that we could have pulsatile blood flow, but we don't because the heart isn't actually contracting hard enough or isn't contracting at all, but at least the electrical conduction is trying. So remember, a ECG is not movement of blood flow or anything like that, or even movement of the heart. It is the movement of electricity conducting through the heart, right? So if we're seeing our P waves and our QRS waves and our T waves in this PEA, that's a good sign that the heart is trying to beat, but it's not beating hard enough. And that's exactly where we're going to give them adrenaline if they are in cardiac arrest. Because the heart is trying to beat, we are going to try and do as much as we can to stimulate it to beat and to increase as much preload as we can into the heart, which is what your adrenaline is going to do. And so therefore, that is not something that we would want to stop. We want to encourage that. You do get different kinds of PEAs, although that isn't quite the realm of the point of this conversation. But in some PEAs, the heart is actually at standstill. And then there are some PAs where the heart is not at standstill and is actually beating, but just not beating hard enough for us to feel a pulse. So you do get different kinds of PAs, but that's a whole nother conversation. The other distinguishing factor that's quite important to mention is that you get these agonal rhythms and you get PEA, right? So what is the difference between an agonal rhythm and a PEA? So a PEA really is defined by a rhythm that could generate a pulse, but isn't. So if you have a P wave and a QRS and a T wave at whatever speed, because you can get slow PAs and fast PAs, that would kind of mean that that is a rhythm that could generate a pulse. But if you have this, strange, like bump here and bump there, and it's not really actually indicating any real conduction to your SA or AV node, then that isn't generally actually considered a PEA. That is considered the agonal rhythm, and is not called a PEA, and it is not treated as a PEA. It's actually treated like asystole because the heart isn't doing anything. So those are quite good or important things to understand about that. So if you did enjoy this video, please hit like, share, and subscribe. And if you enjoyed this, you're probably going to enjoy this video too. So thanks for your time and bye for now.